The most important part of the mental status exam is, of course, when you, as the physician, sits down with the patient and interviews the patient. This is really the best tool that the psychiatrist has to not only confirm the diagnoses, but to get as much information as possible from these individuals. Psychiatry is not like the other specialties where you can order labs, you can get CTs, you can get MRIs, etc. So the best tool that we use is the mental status exam. And what you need to know for the examination, of course, is what are the different parts of the mental status exam. Now, the first thing that appears in the mental status exam is the appearance. So what the person looks like will be very important. The moment they walk through that door, you need to start making an assessment. Are they clean? Are they dirty? Are they disheveled? What is it that they look like? And that will give you a general idea. Another part of the mental status exam is going to be their behavior. Are they having any kind of psychomotor disturbances which could help you with the diagnoses? For example, you could see psychomotor agitation in several disorders. You could see it in anxiety disorders. The people that will move their legs when they're sitting down, the people that are fidgeting in their chairs are all evidence of anxiety disorders. You also have a lot of agitation in patients who have schizophrenia. They are very restless when they're talking to you, and sometimes they cannot sit still as well. There is something called akathisia, which is a generalized restlessness, and this, of course, is nothing more than a side effect of the antipsychotic medication. So what you need to do when you have patients who have akathisia is that you have to lower the dose. Years ago, akathisia used to be called the Thorazine shuffle. If any of you have ever seen psychiatric patients in older facilities, you might see them doing something like this, where they're basically rocking back and forth, or if they were to be sitting down, they're sitting and moving back and forth with their body, and that is the restlessness that is typical of akathisia. And the patients usually describe it as having ants in their pants. And it's very important that you recognize it, because if you do not, what you're going to be doing for these patients is that you're going to be giving them higher doses of the antipsychotics, when in fact what you really need to do is to lower the dose. So the treatment for akathisia will either be 1, lowering the dose, 2, adding a beta blocker, number 3, adding a benzodiazepine, or the best treatment of all, of course, will be to switch to an atypical antipsychotic. Also, another part that's very important is the mood. Mood tends to be more subjective than anything else. Mood is how you feel. If I were to ask you today, how are you feeling? I feel sad, I feel angry, I feel anxious. So it's more of an internal state. Whereas affect is more, I'm going to look at your face and I'm going to determine basically what your mood is. Usually the mood and the affect go together, and when they do, that's a term called congruent. So if you're telling me that your mood is angry, you probably have a very angry look. If you're telling me your mood is depressed, you'll probably be crying. If you just won the lotto and you're very happy, then your mood, of course, should be euphoric or very happy as well. Now, for the purpose of the exam, if they ever use a blunted affect or a flat affect, those are terms that usually are specific for schizophrenia. Blunted affect means an affect that's less than normal, whereas a flat affect means you have no emotion whatsoever on your face. For example, patients who have Parkinson's disease have what's called a mask-like facies, and that means they have no emotion on their face, and that would be what a flat affect is all about. You also want to determine what the speech is for that individual. And this will be important because if patients have any kind of neurological disorder, if they were to have aphasias, if they were to have any speech difficulties, by listening to their speech patterns, you could determine what kind of speech disorder they have. But for the psychiatric purposes, certain things tend to apply. For example, patients who have bipolar disorder, when they are manic, they tend to have what's called pressured speech. And pressured speech is something that you find in the patient that's talking very, very quickly. So they're speaking a lot in a very short amount of time, so their speech is pressured. When patients are depressed, their speech tends to be slow. They don't tend to say much. Patients who are schizophrenic, for example, can have very garbled speech, very difficult to understand. For example, in those that have this schizophrenia, the disorganized type, you might see this kind of speech pattern. So listening to the speech will help you determine the diagnoses as well. Now, it's imperative that you understand what perceptual disturbances are all about. So here is where you need to understand the differences between a hallucination versus an illusion. A hallucination is nothing more than a false perception. So you are in a room by yourself and you hear a noise, so that would be an auditory hallucination. You don't have anything in your mouth and you taste something, and that would be a gustatory hallucination. You smell something when there's nothing there to smell, that would be an olfactory hallucination. And of course, you see something when there actually isn't, and that would be a visual hallucinations. So patients who are psychotic, the schizophrenic patients, tend to have what are called the auditory hallucinations. They're going to hear voices, and the voices they usually listen to or they hear are voices which usually are demeaning, they're negative, they're hostile, it's telling the patient to do bad things. Go ahead and kill yourself or kill your neighbor. And these are the types of voices that are usually quite distressing to the patients. Visual hallucinations, even though can occur in schizophrenia, you'll probably see more visual hallucinations in drug-related questions. For example, patients who are in alcohol withdrawal will typically experience visual hallucinations. And these hallucinations can last anywhere from 1 day to 30 days, so they tend to be longer in duration than the other types of hallucinations. Olfactory hallucinations, such as smelling burning rubber, is something that you can find in patients who have seizure disorder, and it's usually the complex partial seizure. And these are the three types of hallucinations that get most asked on the examination. But as far as schizophrenia, focus on the auditory hallucinations because those tend to occur much more frequently than the visual hallucinations. Now, understanding what hallucinations are, illusions are completely different. Illusions are nothing more than sensory misperceptions. Like a magician would be a master of illusions. An illusion would be that you are sitting in a room, you hear someone talking, but yet you think they called your name. So you actually mistake that noise for your name, and that's what the illusion would be. As far as pathology, you tend to find more pathology in patients who have hallucinations versus illusions. Everybody has illusions, but not everybody has hallucinations. When we assess thought, we're going to assess it in two ways. We want to assess form of thought, and we want to assess content of thought. When we assess form of thought, what we're really trying to assess is how we get our thoughts across. So the way we do that are going to be in 4 different definitions that you need to understand. So you need to focus on what is the difference between flight of ideas versus loose association and tangential versus circumstantial. Now, the difference between flight of ideas and circumstantial, they both involve a rapid shifting of topics. So in both of them, you're going from topic A to topic B to topic C rather quickly. The difference is that in the flight of ideas, there is some type of connection. There's something in topic A that moves you to topic B, and so on. Whereas loose associations means there is no connection whatsoever. So here you have these patients going from one topic to another without any kind of association between one and the other. So thinking about that, patients who have psychotic disorders are more likely to exhibit loose associations, whereas the patients who have flight of ideas are more likely to exhibit the manic symptoms. So the manic patient is euphoric, they need to tell you a lot, so they tend to jump from one thing to another. Now, tangential versus circumstantial are different. Tangential is when you start talking about something, but yet you get off the topic and you never come back. Whereas circumstantial speech is that individual who does get to the desired point in the topic. However, they take a very long route to get there. So they talk about everything else and then they finally get to the point. And those are the 4 things that are commonly asked on the examination as far as what is form of thought. Content of thought is completely different. Content of thought is what it is that you're actually thinking about. For example, if you're having thoughts of hurting yourself, that would be a suicidal ideation, and that would be a content of thought. If you're having thoughts of hurting someone else, that would be a homicidal ideation, and that would be a content of thought. If you feel that others are trying to get you, if you have a delusion of persecution, the fact that you have a delusion is a content of thought. So let's talk about what delusions are all about. Delusions are beliefs that are held by the patients which tend to be fixed and tend to be false. So no matter what you tell this patient, they will always believe that what they're thinking is true. Delusions are psychotic symptoms. You find delusions in delusional disorder, you find delusions in schizophrenia, you find delusions in bipolar disorder, and many other disorders as well. However, looking at the content of the delusion will determine what kind of disorder that patient has. For example, patients who have delusional disorder, what's important about their delusions is that really they're believable. They make sense. It's something that someone could believe in. If I believe that I owned AT&T, it's something that's possible. And that's what delusional disorder is all about. These are individuals who have delusions which are believable, but yet their life is okay. They're fully functioning. They have no problems in any other aspect of their life except this one fixed delusion. And because they're functioning and because their delusions are somewhat believable, they tend to have a much better prognosis than patients who have schizophrenia. Schizophrenics, on the other hand, have what are called bizarre delusions. These are the delusions that are non-believable. These are the delusions that make no sense. You believe that you have a microchip inserted in the back of your head. You believe that you're the king of a faraway planet. That's what the schizophrenics would believe. So the content of the delusions are very different. Because the schizophrenics have what are called bizarre delusions, as you can imagine, their prognosis is going to be very poor. Now let's talk about the sensorium and the cognition. For any of you who have ever done a mini mental status exam, this is basically a very similar situation. So what you have in the sensorium and the cognition is where you are going to assess several things in the patients. The first thing is you want to assess whether the patient is alert and what is their level of consciousness. And this is important because when you are trying to distinguish dementia from delirium, patients who have dementia are typically alert, are typically having an intact level of consciousness, whereas patients with delirium usually do not. They have what's called a fluctuating level of consciousness, and that's one of the main essential features that distinguishes dementia and delirium when you look at their level of consciousness. Another part of this section of the mental status exam is orientation. We want to know if the patients are oriented to time, to place, and to person. Orientation to time means, do you know what day it is? Do you know what date it is? Do you know what month it is? Do you know what year it is? Orientation to place is, do you know what city you're in, what state you're in, what building you're in, what floor you're on? And of course, orientation to person is, do you recognize family, friends, etc. Patients who have delirium typically have problems with orientation, except their problem tends to fluctuate. They could be oriented to time in the morning, but not oriented to time in the afternoon. Whereas patients with dementia, their orientation tends to be intact, but yet it's progressive. So patients who have dementia, what they typically lose first, now this is not a rule, but what they typically lose first is their orientation to time. As the dementia progresses, they then become disoriented to place, and then they become disoriented to person. So usually when you have end-stage dementia, what the patients are usually experiencing is that they don't recognize family, they don't recognize friends. They're basically like small children, not knowing where they are, not knowing anything about themselves. So it's important to remember that there is that pattern of time, place, and person, and that differentiates delirium versus dementia. When we assess memory, we want to assess various things of memory. We want to assess recent memory. And one of the questions that most people like to ask is, what did you have for breakfast? And that's an important question to ask. However, how many of you actually go back and find out what these patients actually had for breakfast? And this is essential because patients who have dementia, during the early stages of their disorder, they understand or they're somewhat aware that they're starting to forget certain events and they're starting to forget certain things. So they're very good at hiding, they're very good at lying, they're very good at trying to fool us into thinking that they're okay. So if you were to ask a patient who has early stages of dementia what they had for breakfast, if they don't remember, they're smart enough to know that to say that they had eggs and they had bacon because they know that those are breakfast items, when in reality they don't remember and they're just making this up. That's why it's important for you to go back and verify whether what they're saying is true. We also want to assess remote memory. What are the things that happen back in their lives? What are the things that happen in history that they would also remember? So again, you need to talk to family members. You need to talk about friends to assess things about these patients in their lives that you could ask them about when you assess their memory. You also want to test immediate retention and recall. And what we do with immediate retention is that you ask the patient to say 3 objects and you ask the patient to repeat them. And if they're able to repeat the 3 objects, then that is intact immediate retention. You then wait 5 minutes and you ask them to repeat the 3 objects again, and that of course will assess their recall. So again, patients who have the cognitive disorders, patients who have dementias, you know that the hallmark of their disorder will be the memory problem. So they will have deficits in all of these areas. Another section will be concentration and attention. And this is a area that tends to have that people with depression tend to have problems with. For example, the way we test concentration is that you might ask the patient to perform what's called the serial 7s or the serial 3s. Now the serial 7s is where you start off with 100 and you ask the patient to subtract 7 from 100, and you have to do this 5 consecutive times. If they're having trouble with the 7s, then do 30 and subtract 3, and that's what the serial 3s are all about. And again, you have to go back 5 times, so it would be 30, 27, 24, 21, and 18. And the trick is not to give the patient a clue. So if the patient, you were to say, what's 30 minus 3, and the patient says 27, do not say to the patient, okay, what's 27 minus 3, because what happens, if their concentration is not the greatest, they forgot what number they gave you. They even forgot what the question was about. So if you repeat the number back to them, you're giving them the hint. So that is what you tend not to do. And that would be a better test for concentration. If they're having difficulties with the numbers, then one thing you could do is ask them to spell a word backwards. And the one usually everybody uses is world, W-O-R-L-D, which would have 5 letters. So again, you ask them to repeat it backwards, and that would be a good test for concentration. Now, patients with depression typically have deficits in their concentration. So it's very common to see patients when they're in their 40s or in their 50s or even in their early 60s come to the doctor's office concerned that they might have Alzheimer's because they're forgetting things. They forget where they parked their car. They forget where they left their keys. And their main concern is that they have Alzheimer's disease, when in fact what they could have is major depression, and that deficit in concentration is nothing more than a part of the depression. But given the age, they're concerned that it could be something else. As far as the other sections, you want to know if these individuals can read and write. So one part of the test is you actually write down a sentence and you ask them to read it. And then you also ask them to write a full sentence. You also want to check visuospatial ability. Now the way to do this, and the way that it was done on the mini mental status exam, is that you can draw 2 interlocking pentagrams and you're going to ask the patient to copy that. And of course you're going to look at whether the points cross, how well they were able to reproduce it from the original design. Now abstract thinking is essential as well. The way we assess abstract thinking is that you're going to determine either whether the person can interpret similarities or whether they can interpret proverbs. Now similarities would be something like, how are an apple and an orange alike? How are a chair and a table alike? The concrete answer would be something like, apple and orange are round and chair and table are made out of wood. When the abstract answer would be that the apple and the orange are actually pieces of fruit, whereas a chair and a table are pieces of furniture. Now, it's important to determine the age of the patient. If you remember psychology from Piaget, as far as the stages were concerned, children do not have abstract thinking until the age of 11. So if you're interviewing a 7-year-old child and you ask the child, how are an apple and an orange alike, what would you expect from that child is the child to say that they're both round, because they do not have the ability to have abstract thinking. However, if you were to be interviewing a 22-year-old, then of course you would expect to have the abstract answers. Proverb interpretation is also a way of determining abstract thinking. For example, he who laughs last laughs best. A rolling stone gathers no moss. And these are the things that you would ask the patient to interpret. You say it to them and you have them say what they mean. He who lives in glass houses should not throw stones. That's a very common one, and most people are able to understand that. But if you were to interpret that in a concrete manner, what you would probably say is something like, well, of course you can't throw stones at a glass house because glass breaks. And that's one of the most common answers that you would find. If you were giving this question to someone under the age of 11, that's what you would expect. However, you would expect a totally different answer when you're over the age of 11. When we assess intelligence, what we're going to do is determine the fund of information and knowledge, and that's a pretty rough test. For example, you can ask the patient, who's the President of the United States? Who was president before him? Who was president before him? Ask him to perform simple calculations, and this will give you a general idea of what the level of intelligence will be for that individual. Now, impulse control is assessed in two ways. It'll either be assessed by history or it'll be assessed by what's happening during the interview. If the patient is able to sit through the interview calmly and able to talk to you without jumping up and punching you in the face, you would definitely have to say that they have good impulse control. If they're unable to do that, then of course their impulse control would be very poor. When we assess judgment and insight, what we're looking at is two things. Judgment is, are you able to act appropriately in a specific situation? So what would you do if you were walking down the street and you find an envelope on the floor and it's stamped, it's sealed, and it's got an address? The appropriate answer would be, I'll find a mailbox and I'll put it in there. And that's what you expect the patients to say. What would you do if you're in a crowded theater and smoke is coming from the vents? The appropriate answer would be, I get up, I find the nearest exit, and I walk out. The inappropriate answer would be, I get up, I yell fire, and I run out of the room, because you know that's probably going to start a mass hysteria in that room. So these are the things that you're looking for the patient to answer. Insight, of course, is, do you have the ability to reflect? Does the patient have the ability to understand what's going on and understand things about his or her life? Now, reliability is basically your impression of the patient's ability to assess his or her situation. Now, let's talk about the interviewing techniques, which are very commonly asked on the examinations. When you start off with an interview, what you try to do is get as much information as possible. And the way we get information from patients is that we're going to ask specific questions that do not have a yes or no answer. And these are called open-ended questions. And what this will do is that it will allow the patient to give us as much information as possible. As the interview is progressing, you need more detailed information, and therefore you switch from an open-ended question, such as, can you tell me about the voices, to when do you hear the voices? What do the voices say? Are you taking your medications, which are then called the closed-ended questions. So the closed-ended questions will be the ones that you specifically can answer yes or no, whereas the open-ended questions will be the ones that you are not able to say yes or no. So always start off with open-ended and continue the interview then with the closed-ended questions. A facilitation is something that we are doing to the patient. It could be any kind of cue, whether it's verbal, whether it's physical, whether it's me just sitting there and nodding my head up and down, and that's a cue to the patient, telling the patient, yes, I'm listening, and continue. So it's very important when we do our examinations, our interviews with these patients, that we do these types of facilitations. And all these do is that they assure the patient that we're interested in what they're saying and they're going to continue. A confrontation is something that you should probably try to avoid. The reason being that confrontations usually will make the patients angry, and you're not going to get a very good interview with that patient, because all you've done is gotten them upset. They're either going to do something to you or they're going to walk out of the room, and that's it. So a confrontation is where you point out something to the patient. So let's say the patient looks angry today and you say, "You're angry. What's wrong with you?" If any of you have ever had experiences like that, all it does when people confront us with those things is that it makes us very upset. So never confront patients, especially in the emergency room, where what's probably going to happen is that you're going to have a patient who has agitation. A reassurance is a comment that the physician is going to make. If the patient perceives this as truthful, then what will typically happen is that the patient will have increased compliance. If the patient perceives it as false, as if though you're lying, as if though you're trying to manipulate him or her, then of course compliance will tend to decrease. So you should always be as truthful as you possibly can to your patients, because you know that will, in the end, increase compliance. A leading question is a question that you should probably try to avoid. The reason being that in the leading questions, the answer is in the question. So for example, if a patient comes in with chest pain to the emergency room, and if the patient is a malingerer, meaning someone who's faking the pain for some obvious gain, if you're giving that patient leading questions, and it's a smart patient, that patient's going to take that information and run with it. So a better question is not to give the patient a leading question. The patient should describe the pain to you, not you give him the clue as to what type of pain it is. Is the pain in your chest a crushing pain? Those are not the things that you would want to give the patient. Have the patient tell you. If the patients come in telling you that they're hearing voices, the best thing is, what do the voices say? And people who've never heard voices are really clueless as to what voices can probably say. But if you were to say to the patient, "Are the voices telling you to kill yourself?" If they're malingering, this is a pretty good question for you to say yes. And then what do? You've got a patient who said yes to auditory hallucinations, telling him to kill himself, and now how do you get that patient to get to the truth? So leading questions, again, try to avoid them at all costs. Let's go over some questions related to this chapter. Question number 1. A 20-year-old man presents to your office complaining of auditory hallucinations for approximately 7 months in duration. He reports hearing his father's voice and at times his mother's voice as well. The patient appears distressed by the hallucinations and wants your help. Which of the following would be the most appropriate statement at this time? So again, understanding that we're starting the interview, what would be the thing that we're looking for? What we try to look for is an open-ended question. And why an open-ended question? Because it's a question where the patient will be able to give us as much information as possible. So choice A, what do the voices say? That is not an open-ended question. Choice B, have you taken medication? That's definitely a closed-ended question. Why? Because it can be answered yes or no. Choice C, why do you think you hear voices? That is, of course, an open-ended question. D is, how is the relationship with your parents? That's definitely an open-ended question. And E, tell me about the voices, is an open-ended question. So we have 4 open-ended questions and 1 closed-ended question. Now the question is, which one of these open-ended question would give us the most information about the patient? Where, if the patient answers it, would the patient be able to elaborate, and it would help us getting information? And of course, the answer would be choice E. And tell me about the voices is where the patient would have to describe what he hears, when he hears it, what he does when he hears it, and that's what would give us the most information. Question number 2. A 30-year-old woman comes to see you after her mother's death 3 weeks ago. Since then, she's complained of depressed mood and feelings of helplessness. While in your office, she begins to cry. Which of the following would be the next step in the management of this patient? So here we have a situation where a patient is telling you bad news, and she begins to cry. As physicians, what do we try to do? We try to have empathy, and we try to assure the patient that yes, we're going to listen to them. We're not going to storm out of the room. We're not going to tell her to stop crying because that upsets us. So we're going to look for an answer where we have empathy and possibly a facilitation as well. We're going to provide some cue that will encourage the patient to continue and that will tell the patient, yes, I'm listening to you. So choice A, I will come back when you stop crying. That has no empathy whatsoever, so of course that is obviously a wrong answer. Choice B, do you feel guilty about your mother's death? Where in the question does it say anything about guilt? So that, of course, is an obvious wrong answer. Choice C, offer a tissue and remain silent. Here we have the empathy, here we have the facilitation. The silence is interpreted as a facilitation. D, go ahead, it is normal to cry. You never say that to a patient. And E, refer to a psychiatrist for further evaluation. This, of course, is obviously wrong. You do not need to refer to psychiatry for any answers on these examinations. The exam wants you to know, they want to know what you're going to do in each one of these situations. So again, looking at all 5 choices, the one that would provide the most empathy and does facilitation would be choice C, offer a tissue and remain silent.